and welcome to our Setup Intensive Care. My name is Karen. I'm one of the advanced nurse practitioners within critical care, and this is Claire, who's going to help me demonstrate or show you what it is about looking after a critically ill patient in intensive care, and just kind of some of the routines that we do every day, and a little bit of an ABCDE assessment. We've set up our patient as realistically as possible to show you what it will look like when you get to our bed space. I'm going to talk Claire through as somebody that is new to intensive care and is not normally involved in the ongoing care of an intensive care patient, and just through things that I would do normally coming onto shift every day. Hopefully this will help you. I know some people is very apprehensive, very scared of the thought of coming into intensive care and having to come and manage, help us manage some of these patients. So hopefully this just helps a little bit and something that you can use further down the line and to help reassure you. PPE in this environment, it depends on what kind of patient you're looking after, so please make sure you've got appropriate PPE on, particular to your patient. For this scenario, we'll assume we've got a non-COVID patient, so we just have standard PPE on that we would wear in intensive care. And again, things might vary a little bit between departments and units, so please take this as a broad, general, basic intensive care patient assessment. I'm going to talk you through what I do every day when I'm looking after a patient.
Okay.
So one of the first things, we would have taken handover from our night colleagues this morning, and they would have given us a history, a background, what's made the patient come into intensive care, what's happened overnight, a bit about his ventilation, his drugs. So we would have gotten a brief or relatively handover from them. It's always useful to make some notes. So one of the first things I do when I get to my patient or get to my bed space is make sure that we are safe. Check all our emergency kit. For the purpose of the video, we're going to leave the curtains open, but normally I would have drawn the curtains around the bed to provide our patients some privacy. Check our bed space. There's nothing obviously on the floor that we can trip over. And part of my emergency checks would be making sure that I've got an ambu bag, which at the moment is hanging at the back of our monitor there, and it's just a normal ambu bag, and make sure it's got a face mask and things attached to it. In intensive care, we normally would have a water circuit, and I'm sure you're familiar with the water circuit out of A&E, and our water circuit is just hanging at the back, and just check that it's connected to the oxygen.
By just turning
the oxygen up, just check. Clearly, if you're looking after a patient that is COVID positive, we really don't want to break the circuit at all. So we're going to be mindful that whenever we turn the patient and things, we're going to not try and break that circuit. But in an emergency, if that tube comes out or something, we might need this. So check that. The other thing we need to check is make sure our suction is working, that your suction is working. And at the moment, our suction is connected to our inline suction there. I'm going to kind of talk you through a general just patient assessment from A to E, and we'll kind of look at the kit. It's important to double check your patient's ID because these patients are unconscious. So we need to make sure that they've got ID band on. Sure. You also need to make sure if they're allergic to something, make sure they've got an allergy band on, and check with their records that it's right. Okay. I think one of the main things that people often struggle with is the fact that the patient's unconscious and they can't talk back to you. Treat our patients and communicate with our patients the same way I'm talking to you, because despite the fact that they are asleep and sedated, we strongly believe that people can still hear you, and they can certainly feel you touch them. So please talk to your patient the same way you would talk to anybody that is awake. So Andy, my name is Karen, and I'm here with Claire, and we're going to be looking after you today. And today is Monday, and it's the 23rd of March today, and we've just gone about 10 o'clock in the morning. So you're in intensive care in Reading, and you've been unwell for a couple of days, but we're looking after you. You're going to feel us touching you and just checking some of your lines. We're just checking all our safety things and just making sure that everything is okay and in place. All right?
So every day you'd kind of orientate the patient to where and when? Okay.
Yes, it's important for further down the line. We want to minimise their post-traumatic stress. So lots of these patients will have post-traumatic stress and delirium. So it's important that we try and orientate them as much as possible, even though they are asleep. First of all, so we're doing an ABCDE assessment. So A, our patient is clearly intubated.
Yes.
I want to make sure that I don't have any cuff leak or anything, or any obvious noise or anything coming from there. So my cuff is inflated, so you can feel that.
Okay.
I'm going to check the cuff pressure, and we'll show you that when we get. Most people will have tube in most adults will be about 22 centimeters at the incisors of their teeth. So if there's some markings along the tube, you can see that.
Yeah.
Yeah, and 22 centimeters should approximately. In our handover, we would have gotten a record of when they intubated the patient and the length of the ET tube.
Okay.
So it's important that we stick to that length, because that will tell us whether the tube is moved or not.
Yep.
So looking at this roughly, we're about 22 centimeters. My tube is relatively well secured with an anchor fast. Lots of places might use, and certainly in patients, the COVID patients that we're going to turn prone, will have tapes, so normal tapes that we would have used in ED, rather than anchor fast, because that will cause pressure damage.
Right.
Yep. Going through our ventilator, we'll go through that. We'll just double check that the settings are the same than what we were handed over to, that the patient is in terms of their mode, their oxygen, what PEEP are they on, I think. So we'll go through that in a minute. So check the position of the tube, check the cuff.
Okay, position and cuff inflated.
And cuff inflated, and make sure that it is secure and that it's not going to move.
Okay.
Okay. Then we're going to move on to B. We're going to look, listen and feel. So we're going to expose our patient, and we just want to make sure we've got equal chest rise. And you should see with a ventilator, it's quite easy. Making sure it's equal expansion. Things. We would listen to their chest.
Yeah.
And in a ventilated patient, you should really hear air entry all the way through.
Yeah.
And we'll go through in some of the clips further down the line what other sounds. So they might be wheezy, they might have some crackles or things. But really in a ventilated patient, we should be able to hear air entry all the way through. Yeah. I would want to check my sats. So currently our patient is very well saturated, 97. And he is on, I think, only on 40% oxygen.
Okay.
Yeah. A lot of these patients, certainly the COVID patients, might have quite high PEEP and high oxygen. So a disconnection of this, we want to prevent that from disconnecting at all. So we just want to make sure that all our fittings are tight and secure, and it's not going to become disconnected.
Yep.
Okay. Going on to C. Again, look, listen and feel. So we're going to look, our patient will have an arterial line. For blood pressure. Okay. Got an arterial line here. We're going to feel that they're nice and warm. Yeah, we're going to do a cap refill. And we're going to feel their limbs bilaterally. We're just going to feel their feet and feel up there. So we like to feel touch. We're very touchy-feely. So we like to feel to where our patient is warm, and they should really be warm all across. Yeah, and that they've got pulses. We're going to just check that no lines are trapped underneath our patient, and we're going to re-zero our arterial line just to make sure we've got an accurate blood pressure. We'll go through that in a bit later. While we're in C, lots of these patients will be on inotrope support. So we'll just make sure on our pumps that they've got, if they're on inotropes, what are they on, how much is it running at, and make sure it corresponds with what's been documenting.
Okay. So just checking the drug against the drug
chart and the prescription and things. For most of our intensive care patients, we will run mean arterial blood pressure, somewhere between 60 to 65, to make sure they perfuse all their organs. But clearly it's against what the target's been set by the team.
And would we get the target in handover?
In handover and during the ward round. So when the team comes back during the ward round, we'll get the target set by them. Temperature check, cap refill.
Yeah.
We try, most people we wouldn't give a huge amount of fluids to. Hopefully they've been resuscitated appropriately. So we try not to give a huge amount of fluid because we're already giving a lot of drugs and feed, so we normally wouldn't give any extra fluid. Patients, all these patients will always be catheterized because they ventilated. So we'll have a urine catheter, which is on that side, and we'll just check. So we do hourly urine output as much as possible, 0.5 ml per kilogram. Might vary depending on the renal state of our patient. So one of the big things that I was just going to mention about inotropes, when you're checking it, is check how much you've got left in the bag.
Yeah.
It's drugs that's got a very short half-life,
Okay.
so it wears off very quickly. So if you've got a patient that's quite unstable and is on a high dose of inotropic support, if the infusion runs empty, you might get quite a dip in their blood pressure.
Yeah. Okay.
And it can be can have quite significant consequences for the patient. So we would always check and see how much is left. And you should have really one ready to switch over.
Okay.
And again, it depends on local policy how you swap over your drug. So part of your checks is just to see how much you've got left, knowing how much is running at, so you can work out how much time you've got left.
Sure.
In order to work out.
Time management.
Part of C, we would try and check just all our lines. So majority of these patients will have a lot of lines.
Okay.
I would want to make sure, one, look at the line, make sure it's nice and clean,
Okay.
and the dressing is still intact.
Yeah.
And then I would just trace all my lines and just making sure, again, checking my infusions. All the lines need to have a date and time of when it needs changing.
Okay.
So again, against local policy,
Fine.
a lot of us will label the lines itself with what drug is in that line, partly for an emergency. You want to know quickly which line is which infusion. Every patient will measure their arterial blood pressure, we'll zero that, and it's the same with central venous pressure.
Okay. So you have them both?
Have them both at level. We try not to tape them to the patient, because again it could cause pressure damage.
Yeah.
So we'd normally just position, but again it might vary a little bit from department to department.
Okay.
If the only thing I would say is if you go into an arrhythmia, so if your patient becomes really tachycardic or bradycardic or anything, I would clearly call for help and start maybe doing a 12-lead ECG.
Just like I would.
Just like you would do on the ward or in ED.
Yep.
But we've got the fortunate patients are continuously monitored, so we can pick up on things really quite quickly. While we're in C, we would obviously check all their electrolytes. So we monitor the electrolytes quite closely, and we'll go through that a little bit later.
Okay.
So going on to D, so obviously majority of our patients are sedated and ventilated. And again, the drugs that we use will vary from department to department.
Okay.
Our patient is currently sedated on morphine and midazolam. We want to make sure that they are adequately sedated to tolerate any intervention that we do. We've got adequate pain control. Majority of the time in intensive care, we would give patients a sedation break every day.
Okay.
Just to see that we're just doing the adequate level of sedation.
Right.
Because we only want them to a point where they'll tolerate what we do to them. So a lot of time, not over sedated. Okay. A lot of times we'll actually have them to a point where they can squeeze your hand and they're aware of what you're doing.
Okay.
But clearly for patients that is lying prone or it's difficult ventilation, they would clearly need to be much more deeply sedated. Sure. So you won't necessarily do a sedation break on them. So we're going to check their pupils. And again, from handover, we would have gotten a baseline of where they are. So any change clearly escalate immediately. Alongside a normal response so motor response. They're clearly not going to have a verbal response because they're intubated. So our GCS is slightly affected. We take the verbal response out, eye-opening, whether they're eye-open to voice, pain, things.
And how would you know if they were in pain, if they're not able to tell you?
So ventilated patients, pain response in them will be tachycardia, hypertension, looking agitated, restless, not really synchronizing with the ventilator very well. Okay. It's clearly sometimes quite difficult to distinguish exactly what it is, but the majority of the time it's looking at tachycardia, hypertension, restless.
Okay, so you might look agitated.
They might look agitated, and suddenly if you turn them, so we use like grimacing.
Okay. Yeah.
Yeah. So it depends on what you do to them. So CPOT score, so facial expression and things. And again, we can go through that in a bit. Please. And there's resources on the computer which we can show you a bit later. The other thing in D is blood sugar. So we control our patient's blood sugar quite tightly, and it's normally somewhere between 4 and 10. So we try not to let them go hyperglycemic. There's lots of evidence to say that critically ill patients do better with tighter blood sugar control. So you'll see a lot of patients end up on insulin infusions while they're critically ill, and not necessarily going to need insulin further down the line, but certainly while they're on the unit. So we need to make sure we check their blood sugar.
Okay.
So E for me is everything else. Technically it means environment, but for me it's everything else that we haven't covered in the first 4 sections. So it would be abdomen, nutrition, DVT prophylaxis. Looking under
your exposure as well.
Exposure, looking under the blankets and things like that. So I would expose my patient. Andy, sorry, we're just going to feel us moving things. So I would want to just check their abdomen, and I'm just looking that it's soft, not distended. I want to listen to their bowel sounds, make sure they've got some bowel sounds, because most of our patients is being fed, and I would expect them to have their bowels open. So again, in our handover, we would have got an idea of when last they had their bowels open. It gives me an opportunity to look underneath the line, underneath the gown, making sure there's nothing trapped. And we're looking for any wounds or pressure areas or things. So normal exposure that you would get. Checking catheter sites, that make sure it's not trapped underneath them or anything. So we expose our patient completely. And then coming down to their legs. We need all these patients, they're immobile, they're lying in bed, and although we try and turn them as much as possible, we need to be conscious about their DVT prophylaxis. So again, local policy, but majority of the patients will end up on floatrons.
And is this?
This is floatrons, So it's basically a pneumatic compression of their leg just to keep the blood flow going. I would take them off and again check the skin integrity underneath it, and there's nothing trapped.
So it's okay to take these off?
It's okay to take them off, yes. And then I would just make sure I put them back.
And how tightly do you put them back on?
Doesn't have to be tight at all. So the other thing we need to be conscious of is eye care and mouth care, because again, eye care, they don't blink. They sleep, they don't blink. So we need to be cautious that the eyes don't dry out. So again, there will be local policies as in how and what you use for eye care. So make sure we look after their eyes, clean it, and sometimes they need natural tears, things to go in. Mouth care, brush their teeth, rinse their mouth out. And that's something we can help you with to begin with, because it's quite scary thinking I have to brush somebody's teeth around the ET tube. So we can do it together. Lips, pressure areas from the tube around their lips. And again, pressure areas from all the monitoring. So SATS probe, might need to move it. And sometimes we click it on their ear. So again, it's just checking.
Checking underneath it.
And move it around. Our patients are, like I said earlier to you, is NG fed, because we like to feed them. So it's very important, check your NG tube. Again, local policy. The problem with NG feed between us and the ward is a lot of our patients get drugs that affect the pH of their stomach content. So we're quite limited in using a pH strip. So it will be X-ray to begin with, and then making sure that we document the length of the tube, that it's not moved and things before you give any drugs or anything through that. So again, documentation is vital in this. So if you've moved your patient or anything before you give any drugs through that, make sure that your tube is not the right place. And our patient is being fed. We've got our pressure bags, and we'll go through our drug chart just to make sure everything matches, and there will be new things on there. That is nearly my whole A to E assessment in a very quick nutshell. We'll go through. We do this at least once or twice a shift. So there's plenty of opportunity, and we'll go through more individual checks as we go across the day.
Great, thank you.
I think it's time for a sip of water.
Thank you very much.